Scleroderma or systemic sclerosis. I'm Dr. Vardanyan, Associate Professor at the Department of Rheumatology of Yerevan State Medical University. What is systemic sclerosis or scleroderma? This is a multi-system disorder which is characterized by functional and structural abnormalities of blood vessels, by fibrosis of the skin and internal organs, immune system activation, and autoimmunity. The prevalence of systemic sclerosis is from 4 to 12 new cases per million per year. Susceptibility is a host factor. Age, peak occurrence is at the age of from 35 to 65 years old. We have here female predomination. Females are from 3 to 12 times more susceptible for occurrence of systemic sclerosis, and of course here we have genetic background. The classification. Scleroderma is divided into two groups. First is systemic sclerosis, and the second is localized scleroderma. In contrast to systemic sclerosis, in case of localized scleroderma, we only are having skin changes, and the skin changes are patchy. Usually, localized scleroderma is not involving internal organs and systems and usually being treated by dermatologists. So what is diffuse cutaneous systemic sclerosis? Here we are having proximal skin thickening, which means that the thickening of skin is coming over elbow joints on upper extremities and over the knee joints on lower extremities, including the trunk. We are having distal and proximal extremity involvement, and often the trunk and face are involved. Here, a tendency to rapid progression of skin changes is described. There is rapid onset of disease following Raynaud's phenomenon, early appearance of visceral involvement, and poor prognosis. In case of limited cutaneous systemic sclerosis, the skin changes are not coming over the elbow and knee joints, are not involving the trunk. Here we have symmetric restricted fibrosis affecting of distal extremities and face and neck. Prolonged delay in appearance of distinctive internal manifestations, prominence of calcinosis and telangiectasia, and good prognosis. The former name of limited cutaneous systemic sclerosis is CREST syndrome. CREST syndrome includes calcinosis, Raynaud's phenomenon, esophageal dysmobility, sclerodactyly, and telangiectasia. The third type of systemic sclerosis present as overlap syndromes. What is overlap syndrome? In this case, we have features of systemic sclerosis together with those of at least one other autoimmune rheumatic disease, for example, systemic lupus erythematosus, rheumatoid arthritis, or polymyositis. What etiological factors are we usually discussing in this case? Here again, as in any autoimmune disease, we are speaking about the environmental factors and the genetic factors. Environmental factors. Here we discuss the role of silica dust, organic solvents, biogenic amines, urea formaldehyde, polyvinyl chloride, rapeseed oil, bleomycin, tryptophan. Here we speak about the genetic predisposition, role of HLA system, and the role of single nucleotide polymorphisms. And of course, we will speak here about the defective immunoregulation. We have cell-mediated autoimmunity associated with CD4 and CD8 cells, role of cytokines, and of course here we have humoral immunity with hypergammaglobulinemia, autoantibody production, and in this case, in more than 95% of cases, we have anti-nuclear antibody positivity. So, what is happening here? Usually, genetic factors, genetic susceptibility, and external stimuli are acting on cells on immunocompetent cells, causing cellular immune activation. Which cells are included here? Mainly macrophages, B cells, T cells, and mast cells. These cells begin to synthesize profibrotic cytokines, which from one hand are causing synthesis and accumulation of extracellular matrix proteins, which will cause activation of fibrosis, which on the other hand will cause vascular changes because these profibrotic cytokines are causing activation of the growth of connective tissue under endothelium, causing vascular changes, and in skin and internal organs, causing fibrosis of skin and internal organs. So, what is vasculopathy? What is scleroderma associated vasculopathy? Here we have intimal and medial hyperplasia and proliferation of connective tissue, capillary destruction, adventitial fibrosis, and compromised lumen. And as a result, there may be digital vasculopathy, pulmonary arterial hypertension, and scleroderma renal crisis. Let's speak about the clinical features of systemic sclerosis. First, we will speak about the vascular abnormalities, especially Raynaud's phenomenon or digital vasculopathy. What would we have? Cold hands and feet with reversible skin color change, white to blue to red. This happens in cases when the vessels are having preserved ability to contract and relax. These skin changes are induced by cold temperature or emotional stress, and this is initial complaint in majority of patients. And 90% of patients with skin changes are having Raynaud's phenomenon. We even can say that Raynaud's phenomenon is an essential clinical presentation in case of systemic sclerosis. In cases when there is already obliterative vasculopathy, we will have already digital ischemic injury. On this picture, you can see Raynaud's phenomenon with widening of fingers. On next picture, you will see already bluish coloring and cyanosis of the fingers of hands. And this picture, my favorite, here you see cyanosis, you see telangiectasia, and you even can note the swelling of the fingers. This kind of clinical presentation is called puffy fingers. This is one of the early signs of systemic sclerosis. If we perform arteriogram in case of advanced Raynaud's phenomenon, we will notice the narrowing and occlusion of digital arteries. And here, proximal vessels, arcades, and metacarpal vessels are widely patent. On the next slide, you can notice expressed telangiectasia. What is telangiectasia? This is local disruption of angiogenesis, and these lesions are blanched by pressure. The next clinical feature includes the skin. Skin involvement has its stages. First is edematous phase, second is indurative phase, and the third is atrophic phase. The skin is firm, thickened, bound to underlie soft tissue, and this will cause decrease in range of motions, loss of facial expression, inability to open mouth fully, and contractures of the fingers. The contractures on the fingers are called sclerodactyly. Here on this picture you can see the edematous phase when the disease is beginning, and these changes are called usually puffy fingers. On second slide you will see already the skin induration when there is already fibrosis, and you see the fingers are so-called gathering, and this is the initial stage of contracture of the finger, initial stage of sclerodactyly. In this slide, you can notice already acrosclerosis when we see already expressed contractures of the fingers in case of systemic sclerosis. The next one is facial changes. What can we see on this face? We can see tight, thin lips with vertical perioral furrows, and this sign is called pouch phenomenon. Usually it is caused by the difference in distribution of fatty tissue around the mouth and around the cheeks. When there is indurative stage around the cheeks yet, around the mouth we have already atrophy. That's why the skin around the mouth is gathering in vertical perioral furrows, and this is very specific sign in systemic sclerosis. Here also you can see a specific face of the patient with systemic sclerosis with telangiectasia and the furrows around the mouth, pouch phenomenon. If the patient is not receiving a specific treatment, the skin involvement will go further, and this will accompany already vasculopathic changes, and here we can find out ulceration, loss of soft tissue of fingertip, which is called pitting scars. I will show you the pictures later. Pigmentation, calcific deposit, and capillary changes. Musculoskeletal system. Here we may have polyarthritis and flexion contracture, and muscle weakness and atrophy. Here on this slide you can notice pitting scars on the tip of the fingers, and as well as puffy fingers. This is one of the early signs of systemic sclerosis. In cases of chronic decrease of blood flow in fingers, we would have terminal digit resorption. If you pay attention on the fingers, you will see the shortening of the phalanx of the fingers on these pictures. Here also you can notice the shortening of the fingers, and this is because of severe digital vasculopathy. On this slide you can see the X-ray of a patient with terminal digit resorption, and you can clearly see the resorption of the bones. One of the signs of Krebs syndrome or limited scleroderma is calcinosis cutis. Here you can see the calcinosis, the calcium deposits under the skin. And here is the X-ray. This is my favorite picture. Here you can see the calcium deposits, and you can also see the shortening of the fingers, and you can see that one of the fingers had lost the distal phalanx. The next presentation is involvement of internal organs. In contrast to other autoimmune diseases, in systemic sclerosis, involvement of GIT is very common. First of all, there is involvement of esophagus, so it will cause the hypomotility and retrosternal pain, reflux esophagitis, and strictures. In stomach, we would have delayed emptying. In case of involvement of small intestine, there will be pseudo-obstruction, paralytic ileus, malabsorption, weight loss, or cachexia, and of course, diarrhea. In case of involvement of large intestine, the patient would have chronic constipation and fecal impaction and formation of diverticula. On this slide, you can clearly see the changes of esophagus uh, and the dilation of the lower part of esophagus. That's why these patients who are having systemic sclerosis, one of the common signs is dysphagia. These patients are having difficulty with swallowing of the hard food. On this slide, you can see the X-ray. This is barium enema study, and you can clearly notice multiple wide-mouthed diverticula of colon with broad basin neck. And in these cases, in case of systemic sclerosis, these changes of large intestine are asymptomatic. Here also you can clearly notice diverticula on this X-ray picture. The next organ, which is very often involved in case of systemic sclerosis, is lung. So 2/3 of patients are affected, and this is the leading cause of mortality and morbidity in later stage of systemic sclerosis. What pathological changes are found here? Here there is interstitial fibrosis and intimal thickening of pulmonary arterioles, primary pulmonary hypertension. What kind of complaints would our patient have? This is dry cough mainly and breathlessness. So, interstitial lung disease has its stages. First, it is inflammatory phase, and on investigation methods on X-ray or CT scan, we would find out ground glass opacities and linear infiltrates. And usually the changes are located on lower 2/3 of the lung fields on CT scan. That's why we say that this is basal pneumofibrosis. In case of fibrosis, that we say that this is the late phase of involvement of lung in framework of systemic sclerosis, and there is a specific pattern on X-ray which is called honeycomb. What do we use in order to diagnose interstitial lung disease? We use pulmonary function test. We have restrictive pattern with low FVC, a low residual volume, and low DLCO. We use high resolution CT scan. Usually the bronchoalveolar lavage is not required, and lung biopsy is not required to assess and to confirm interstitial lung disease in case of systemic sclerosis. And interstitial lung disease is most commonly associated with diffuse scleroderma, and in patients with interstitial lung disease we often have positive antibodies for anti-topoisomerase 1, or otherwise called anti-SCL70 antibodies. The next presentation of involvement of the lung in framework of systemic sclerosis is primary pulmonary hypertension. The symptoms are exertional dyspnea. The frequency is 10 to 15% of patients with systemic sclerosis. So what is the definition of pulmonary hypertension? How do we confirm it? This is mean pulmonary artery blood pressure more than 25 millimeters at a rest of more than 30 millimeters with exercise on the right heart catheterization. Estimated systolic pulmonary artery pressure should be more than 35 millimeters hydrogram on echocardiogram. In pathogenesis, we are having intimal fibrosis and medial hypertrophy of the pulmonary arterioles and arteries. So on this slide, you can clearly see the presentation of pulmonary hypertension on X-ray. It is shown here, as you see, either on X-ray or on Doppler echocardiogram. And on this slide, you can clearly see the honeycombing of the lung in case of pulmonary fibrosis. The next clinical presentation is involvement of the heart. As in any autoimmune disorder, we may have involvement of all layers. The most common involvement is pericarditis, then myocarditis with fibrosis of myocardial fibers and development of heart failure. Next involvement includes involvement of the kidney. Usually it happens in case of diffuse scleroderma in association with rapid progression of skin involvement. Pathology. Intimal hyperplasia of the interlobular artery, fibrinoid necrosis of afferent arterioles, and glomerulosclerosis. What do we have clinically? In contrast to, for example, systemic lupus erythematosus, we never have acute nephrotic or acute nephritic syndrome in this case. Usually we are having non-nephrotic proteinuria, abnormal sediment, azotemia, and microangiopathic hemolytic anemia, and rapid progression to renal failure. One of the complications of kidney involvement in framework of systemic sclerosis is scleroderma renal crisis. What is scleroderma renal crisis? This is abruptly developing severe hypertension in rise of systemic blood pressure by more than 30 millimeters hydroargyrum and diastolic blood pressure by more than 20 millimeters. Then we have one of the following: increase in serum creatinine by 50% over baseline, or creatinine more than 120% of upper limit. We're having proteinuria, hematuria, thrombocytopenia, and hemolysis. This change can cause headache, encephalopathy, seizures, and left ventricular failure. 90% of patients are having high blood pressure, but it can also occur with lower blood pressures, and this confers worse prognosis. Which are the main risk factors for renal crisis? First is rapidly progressive skin thickening within the first 2-3 years. Steroid use, if prednisone is used in a dosage of more than 15 milligrams per day. Presence of antipolymerase III antibodies, and pericardial effusion. So this is one of the causes that usually rheumatologists are not using steroids in high doses in case of systemic sclerosis, because it is known that steroid use may cause renal crisis. Here you can see kidney arteriogram. From left side you can see a normal kidney arteries, and from the right side you can see kidney arteries affected by systemic sclerosis. You can see narrowed and in some points disappeared arteria. Here you can see the histological pattern of kidney basal involvement in case of systemic sclerosis, and you can clearly notice intimal arterial fibrosis and thickening of the wall of the artery. Very often in framework of systemic sclerosis, we may have also secondary Sjogrens syndrome. So what is Sjogrens syndrome? This is autoimmune inflammation of exocrine glands, and usually the patients with systemic sclerosis experience xerostomia and xerophthalmia, dry mouth and dry eyes. So which antibodies are related to lupus? So what do we do to diagnose lupus, to confirm the lupus process? Of course, we have criteria. About the criteria we will speak later. But which antibodies are usually linked to systemic sclerosis? First are anti-nuclear antibodies, which are present in 95% of cases in case of systemic sclerosis, and these antibodies are present in both types, either diffuse or limited sclerosis, and we know that this is one of the earliest signs of systemic sclerosis. Anti-centromere antibodies are, are usually present in from 10 to 20% of patients and usually are associated with limited scleroderma. With CREST syndrome, digital loss, primary hypertension of pulmonary artery. Topoisomerase 1 antibodies or ACL70 antibodies are present from 15 to 25% of patients, and these antibodies are associated with diffuse cutaneous systemic sclerosis. They are present in interstitial lung disease and cardiac disease. RNA polymerase antibodies are present again from 10 to 25% of patients associated with diffuse cutaneous sclerosis and associated with renal crisis, cardiac disease, and tendon friction rupture. Antifibrillin or U3-RMP antibodies are present in more than 40% of patients associated with diffuse systemic sclerosis, and they are seen in African American males and associated with pulmonary disease. U1-RMP antibodies are present from 5 to 35 patients. Percent of patients usually present in limited systemic sclerosis and associated with mixed connective tissue disease. Usually these antibodies are seen in case of overlap syndromes. The next investigation, which is nowadays essential for diagnosis of systemic sclerosis, is the nail fold capillaroscopy. During the nail fold capillaroscopy, which is performed by a special apparatus, when we get a pattern on PC monitor, we choose the average capillary length of the distal capillary row. And then we should perform a position of 1 millimeter long counting line in the middle of this and to count the number of capillaries. The normal ranges on 1 millimeter is from 9 to 14 capillaries and the final number is 12. So the number of capillary loops on 1 millimeter range should be no less than 12. So what is happening in case of systemic sclerosis? In case of systemic sclerosis, we are having very specific changes of nail fold capillaroscopy. That's why beginning from the year 2013, the assessment of the capillaries by nail fold capillaroscopy is included in a diagnostic classification criteria of systemic sclerosis. So on normal pattern, you see normal capillary loops. In early pattern, if you're attentive, you will see that the number of capillaries begins to decrease, and we can note already the formation of giant capillaries. In active pattern, you see that we have lost all normal capillaries, and here we see only giant capillaries, and on the upper side of this picture, you can see the hemorrhages. And in late pattern of systemic sclerosis, there is already neoangiogenesis. Please note, please compare the normal pattern of capillaries and the late pattern of capillaries. So different picture we have here. So what criteria nowadays we use for diagnosis of systemic sclerosis? Again, these are criteria which were invented by ACR and Euler in 2013, and we have clinical domains and major criteria and sub-criteria, and every criteria, as you see, has its point, has its weight, and usually we confirm the diagnosis of systemic sclerosis when we gather 9 points. So what clinical domains do we have here? Skin thickening, and here we have sub-criteria. Fingertip lesions with its sub-criteria. Telangiectasia, abnormal nail fold capillaries. Please notice this sign. Lung involvement, here we consider either ILD or pulmonary artery hypertension, Raynaud's phenomenon, and uh, systemic sclerosis related antibodies. Here we have all these antibodies that we discussed before. So we should have uh, 9 points to confirm, 9 and more points to confirm systemic sclerosis. Let's speak about the treatment. First of all, we would speak about the treatment of Raynaud's phenomenon. So first of all, we should speak about a non-medicamentouse treatment. So the patient should avoid cold exposure, use layers of warm and loose fitting clothing, and of course quit smoking. The next thing is the usage of vasodilators. Uh, the classical presentation and the classical drug to use in case of systemic sclerosis to treat the Raynaud's phenomenon is calcium channel blocker. Usually we use here dihydropyridine, calcium channel blockers, nifedipine, amlodipine, etc. Nitroglycerin patches may be used in this case. In refractory Raynaud's phenomenon, we begin to use phosphodiesterase 5 inhibitors, sildenafil, tadalafil. And in serious diseases, when there are serious changes of digital arteries, we would use parenteral prostanoids, for example, iloprost. For the treatment of gastrointestinal changes, for the treatment of reflux, esophagitis, and dysphagia, it is needed to elevate the head of bed, small frequent meal. One should avoid lying down within 3-4 hours of eating, abstaining from caffeine-containing beverages, stop cigarette smoking, and to use H2 blocker or proton pump inhibitor. We also use pro-motility agents, for example, metoclopramide, and in case of malabsorption syndrome, we may also use broad-spectrum antibiotics. Treatment of skin disease. In advanced skin involvement, in case of systemic sclerosis, we have the several options. First of all, methotrexate or mycophenolate mofetil, and there is a current trial with tocilizumab or Actemra, the brand name. What is tocilizumab? These are monoclonal antibodies against IL-6, and rituximab. What is rituximab? These are monoclonal antibodies against CD20 cells of CD20 receptors of B cells. And according to the later guidelines for the treatment of systemic sclerosis, it had been proven that hematopoietic stem cell transplantation may also play a positive role in the process of the treatment of systemic sclerosis. Pulmonary involvement. So how would we treat interstitial lung disease with active inflammation? So here we have options. Either we use mycophenolate mofetil or cyclophosphamide IV, or again hematopoietic stem cell transplantation. For pulmonary hypertension, usually vasodilators are used. Either we use endothelin receptor antagonist bosentan. Again, here we speak about phosphodiesterase 5 inhibitors, sildenafil, and again IV prostanoids, epoprostenol, iloprost. For the treatment of renal changes, usually we cannot advise something very serious, with exception for early detection and AC inhibitors. It is known that 1 year's survival without AC inhibitor is 15%, and 1 year's survival with AC inhibitor is more than 70%. So every time when we suspect or we confirm the renal involvement in case of systemic sclerosis, we should use AC inhibitors. If we catch the patient at a stage of terminal renal failure, we would use dialysis and think about the renal transplantation. The prognosis of disease. The prognosis is quite variable and difficult to predict. Cumulative survival. So 5 years survival in diffuse systemic sclerosis is 70%, in limited is 90%. 10 years survival in diffuse is 50%, in limited is 70%. So the major cause of death of our patients with systemic sclerosis is renal involvement, cardiac involvement, and pulmonary involvement. Thank you for your attention.